Good morning.
Good morning.
How are you?
All right, and yourself?
I'm well.
Good.
Okay, I'm listening for stuff. Okay.
I don't hear anything.
Well, happy Black History Month 2024.
Yes.
Yes, the first Saturday here. Let me stop this banner here. Okay, all right. Yeah. So how was your week?
It was busy as usual, but I'm glad it's over.
Good morning, Renita.
How about yours?
I'm so tired. Let me just say. Did you see what time I put all this stuff out last night? I'm so tired.
Mm,
It's been, it's been, it's been. Did I tell you? Well, on a personal note, did I tell you about my daughter's friend?
no.
No. Okay. So my daughter, my oldest daughter, her friend. I guess it's um almost 4 weeks now. She had a stroke. She's 37 years old.
Oh my
And
God.
yeah. And then she had blood clots. So before they could even address the stroke stuff, they had to have brain surgery and remove these clots. Well, these clots keep forming. They don't know why, what, they don't know what's going on. So she's been in the hospital. So I've been going to visit her in the hospital on top of all the other stuff and just giving her words of encouragement. She is, and she's so silly. She actually used to come. I had a Saturday, or I'm sorry, a Thursday line dance class at my house. So during the pandemic, everything was online. And then we slowly, I said, well, y'all come to the backyard. So then we started doing it in the backyard. We could space out, we could do it in the backyard. But then and when it got cold outside, we would just go back online. But they refused to get online and they wanted to come to the house. So she would always be at the house. And so I don't know how much line dance and stuff, and I know I'm just rattling, but she wanted to learn the Tamia dance, which is 20 years old. I mean, this dance is old as they come, but it has for the last 4 or 5 years had a resurgence. And so she was hell bent. I want to learn a Tamia dance. I want to learn a Tamia dance. And so I was like, okay. So she mastered that. So anytime the little beat come on, she's like, yes, that's my song. Here we go. So when I went to visit her, I was like, yeah, we gonna be dancing. And she was like, Tamia. And so my daughter was with us. She was like, you want me to play the song? And so she would do the thumbs up. She was like, yes. So she played the song. So why was she doing the steps with her fingers in the hospital? I was just so tickled. Like, oh my God. And she was like, yes. So it's like, yeah, we're gonna be dancing this summer. We're gonna be dancing this summer. And I was so touched because her daughter, she has two teenage daughters. Her daughter turned 16 Thursday. And so she was in her feelings and feeling some kind of way. And she was like, she kept drawing. Somebody finally give her some pen and paper. I was like, yeah, because I don't understand what, like, she'll do this and it. I don't know what that means. Ma'am, you done created your own sign language. I don't know. I do know I love you. She says that all the time. I love you too. I love you too. She does that all the time. But so she was writing and she kept drawing these hearts. And I'm like, okay, hearts. And then these little squiggly lines. I said, okay, you lost me with the squiggly line. What are you? I'm trying to figure out what you're trying to say. So then she was like, heart balloons. And I was like, oh, okay. So I made it a mission to find some heart balloons. And so I don't know if she wanted to give them to her daughter for her birthday or she just wanted to have them. But I got a dozen heart balloons and put them in a room. So when her daughter came to visit her that day on her birthday, they were there. So it was, and I got to meet her daughter because I never met her daughter. Well, both of them. But yeah, it was a whole thing. So that's been added to my plate. So I'm sleepy. So when I normally go to bed at 9 o'clock, I can't go to bed. I still have work to do. So I've been up since 11, but I wake up at 4:30. So my whole world is a mess. But I'm here. I feel like silly, but I'm here. And then I did go see Origin. And if you have not seen that movie, it is beyond excellent. It is thebomb.com. Lord, I hope I don't be flagged because I said something about the bomb. But anyway, it's about racism versus caste, and we've talked a little bit about that before when we dip and dive into um, public health. But this is so good. I so much so I went to the library and got the lady's book that the movie is about, and I plan to read it cover to cover. The movie was just Ava DuVernay, Anjanae Ellis. I think she got a new last name, Taylor. I think it was everything, and it talks about slavery, the Holocaust, and the current situations with the Dalit, I think I'm saying it right, in India. And that still is going on today. And, she was like, the way people treat people, it can't necessarily be about race because Indian people are the same race. The Germans and the Jewish people, they're white. They're the same race. So how, and so it was about caste. And then she broke down like all the ways that people break people down to make one feel better than the other, and how then that creates how they treat people. It's off the chain. I was like, I was glued. I took my mama. We was glued like, oh my God, oh my God. So yeah. If
Yeah,
Go ahead.
that's an interesting premise, but but because those are the two age-old um, tools, classism and racism. But in this country, race trumps everything. So,
Well, they talk about that because they also talk about how folks have visited America, and what they feel when they get here, or what they see when they get here, based on how folks are treated. And it's all over the place. It's very good if you get an opportunity. And I think at some point, Ava DuVernay um, got inked a deal for Hulu, so they'll be doing something with it on Hulu as well. So yeah, but it was so good. Oh, it was so good. So I added that to my plate too. So that's all of the things, all of the things. All right, all right. Let's get started. I'm sorry, I just been going on because I'm
so
sleepy. So welcome to our Saturday morning tea, where we discuss, as you see, all things, but we primarily discuss health information, news, education, certification tips, and entrepreneurship. Pretty much the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I am Clarice Warner. I am the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, the heart of it all, that specializes in revenue cycle and regulatory compliance and education. Now, before we go on, and I'm going to say that a couple times, let me ask you, do you know what it takes to be a certified marketable medical coder? Well, before I introduce you to my co host, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right, all right. So if you are interested in getting more information about the 5 steps to become a certified marketable medical coder, then check out the video description for the link. So joining me today is my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a very long time. In 2014, I transitioned from the bedside as a nurse into HIM. And in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other healthcare professionals with a clinical background transition into the wonderful world of HIM.
And how's all that going?
It is going well, but it's
Oh, please.
a little tiring.
Yeah, I feel you on that one. I feel you. I feel you. It's something else out here in these health information streets. It's but the crazy part is it's been this way for a long time. Some things are just now being uncovered, if you will, slowly but surely. But yeah, 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 gotta love it or not.
Yeah, absolutely.
Gotta
Because if
love
you
it or
didn't,
not.
you couldn't do it.
That's true. That's true. So let me remind you that you can join in and add to the conversation. So don't be shy. Your opinion matters and is welcomed here. So, friends, use the chat. That's your friend. That's your friend. If you have a question, please type Q first so that we know it is a question and we don't miss it because I know y'all like to be comedians over there in the chat as well. And we love y'all for it. Good morning, Rami. I hope I'm saying your name right, or Romy. Good morning. Welcome, welcome. And good morning, Miss Vicky. Good morning. All right, all right. So if you are joining us or just now joining us or watching the replay, today we are breaking down CMS's latest guidance on EMTALA and Code G2211. But first, but first, uh-oh, I'm pressing too many buttons. Let's get into our church announcements. Yes. Oh, wait, I forgot to show our side. Look at us on a whole church fan. All right. So this week, Lord, okay, let's see. I don't even know where to begin. Let's start with our friends over at the AMA. Now, you know, they have made it a mission. And actually, you know, I joke and kid and all of the things, but they about their business. Let me just say that. They about their business. They put their money where their mouth is. Um, and they doing the thing. Now, some things they're winning, some things they're losing, but they stand 10 toes down, I'll say that.
As the kids say, they standing on business.
They standing on business. Yes, yes. Um, and they not playing with nobody. So, one of their fights is about scope creep. And pretty much they feel like their motto has been that patients deserve care that are led by physicians, who they say are the most highly trained healthcare professionals. And so they fight for all care to be led by physicians across this country, at both the state and federal levels. So that's pretty much the mantra that they're sticking to and standing on. So now their scope creep here has added a new group. It's now the psychologist compared with the psychiatrist. Um, and again, the feeling is because of the medical, which I'm like, because of the medical training that psychiatrists receive, they feel like that distinguishes them from psychologists and makes them more adapt to prescribing medication. So really this all comes down to the ability of psychologists to prescribe medication to their patients. And so they're trying to say that maybe that's something that they should not be allowed to do. They go into talking about how the amount of time they spent, the number of hours, the regular spiel that they've been doing with everybody. But just really wanted to say, while one physician, Patrice Harris, MDMA, a board certified child and adolescent psychiatrist in Atlanta and former AMA president, was quoted as saying, psychologists play a valuable role in helping patients with their emotional, mental, and behavioral problems and providing interventions such as talk therapy. But when it comes to safely and effectively prescribing psychotropic medications that can impact the whole body, the medical education and training that psychiatrists and other physicians receive has no peer. So I know there was also a move to, and that's not part of, well, I don't know if it's part of the AMA's little spiel or not, but there was also a move to have like your primary care physicians or your general practitioners or family medicine practitioners also provide mental health or behavioral health services as well. So I don't know if they all lump them together. I don't know. But I just wanted to bring to your attention that the fight still continues with the AMA. And now they've added this. I didn't know. There were a couple other things. So we already knew about nurse practitioners and physicians and physician assistants and physicians. But they're also doing nurse anesthetists compared to anesthesiologists, optometrists compared to ophthalmologists, pharmacists and physicians, and naturopaths compared with physicians. So yeah, that was part of that. Mr. Jesse, did you have any comments?
Normally, normally I bash the compassionate sacrifice people, but when it comes to mental health, well, for number one, I always thought there was a difference between psychologists and psychiatrists. I thought that I'm not against psychologists prescribing medication. I'm not, but I think I am against psychologists prescribing certain classes of psychotropic medication, because I remember I worked at a mental health clinic. I don't even know if this drug is still out, but it was called Clozaril, and you couldn't get it dispensed. You had to have your white blood count drawn weekly, because it could cause a dip in your white blood count, and you had to have the labs drawn, and it had to be faxed to the pharmacist every week before they could dispense your medication.
Mm-hmm.
And then there are some other psychotropic medication that can increase your blood sugar. So I'm kind of on the fence about that one. I can see what they're saying, but I think that there's still some room to use psychologists and allow them to prescribe.
I do too. Yeah, so that's that. The other thing, you started this last year, and I said I loved it so dearly and would pick it up. And since we're talking about behavioral health and psychology and all of the things, for Black History Month, Mamie Phipps Clark, PhD, and Kenneth Bancroft Clark, PhD. Mamie was the first African-American woman to earn a doctorate degree in psychology from Columbia University. She previously earned both her bachelor's and master's degree from Howard University. Her experience in college and specifically graduate level courses helped her realize the shortage of psychological services available to the African American community and other minorities. The Clarks are best known for the famous doll study, in which more than 200 Black children participated. Both Mamie and Kenneth Clark worked on the study, providing invaluable evidence in favor of ending school segregation in the Supreme Court case Brown versus the Board of Education, citing that school segregation was psychologically harmful to Black children. Dr. Kenneth Clark was the first ever Black president of the American Psychological Association. Dr. Mamie Phipps Clark's dedication and passion for adequate mental health services for all prompted Dr. Clark to open her own agency to provide comprehensive psychological services to the poor, Blacks, and other minority children and families. In February 1946, Dr. Clark and her husband opened the doors of the Northside Center for Child Development for those in the Harlem area. She worked in the center, counseling and providing other psychological services from 1946 until 1979 when she retired. Although retired, Dr. Mamie Phipps Clark served on different advisory boards and was still very active within her community. So that was our Black History moment. And then this last one made me roll my eyes and find my Invest in Black Women shirt. Okay. So, and we'll talk more about this one in the meeting after the meeting. The Fearless Fund is fighting against defenders of white supremacy. Well, what is the Fearless Fund, you may ask? So the Fearless Fund is, let me find, the Fearless Fund was kind of brought together by a group of, I think, women, actually, Black women, to help get funding for their entrepreneurship. So help them, a lot of women or a lot of people aren't privy to venture capitalists and that whole big pool of money. So the Freedom Fund was put together to kind of do the same thing, but with the caveat to help fund and grow women in African American and women businesses. And so a person, Bloom, who is, I forgot what they said, Edward Bloom, he's a
He's the same one behind the Asians in Harvard.
Yes, correct. Well, he was behind that whole fight with that. Yes. So now he's turned his sights on this fund that is 1% of money. The Black women entrepreneurs receive less than 1% of venture capital funding. And so they're fighting so they can have at least their 1%. And it's a whole thing. So, yeah.
But even 3% of venture capital money goes to non-Black people, period. I mean, non-white people, 3%. So, yeah, we can talk about that later.
Yeah, so more to come on that over in the meeting after the meeting. And if you are a Patreon member, and you can find out more in the description, you can be privy and join us after the Saturday morning tea at 10:15. Okay. The other church announcement, I'm running on with church announcements, is we will not have, it's all a power game and the patient pays the price and is not getting the health care they need. Oh, I think she was talking about the other thing. Okay. We will not have a Saturday morning tea next Saturday. Actually, I was supposed to go to 2 funerals today. I have a funeral and a memorial next week as well. So we won't have, we won't meet next week, but I'll have some tidbits. So especially if you're part of the YouTube community, I'll be dripping and dropping stuff. So you'll find some stuff there. Mr. Jesse, did you have anything for church announcements today? Okay. All right. So let's get this party started. Let's get it started. I was thinking of one song, but in my spirit just hit me with, let's get the MC Hammer. Let's get like, wait a minute, girl. Don't forget about us. Don't forget about us. Okay. So let's talk about I was on the CMS did one of their sessions for physicians. That I think they do these monthly, and they talked about the guidance that they provided related to code G2211. And we talked about this before. This is a new add-on code for outpatient office and outpatient evaluation and management visits. So it's only for 99202 through 99205, which is the new patient office and outpatient evaluation and management codes, or the 99211 through 99215 section, which is the established patient ones. It doesn't matter the specialty. They don't restrict this code G2211 to any specialty at all. So they put out MedLearn Matters MM13473. There's also one that talks a little, that adds some additional information. It's 13472. This one was released January 18th. Of course, it has a retroactive effective date from January 1st because the code was effective at that time. And the implementation date is February 19th, 2024. So this MedLearn Matters pretty much just gives you additional guidance and information on how to use the office and outpatient evaluation and management visit complexity add-on code. Like I said, I listened to the CMS session where they had some other stuff that they was talking about, but this right here took the stage. And the presenter talked about this MedLearn Matters, and he talked about, but there's also a Q&A. And I'll find that Q&A, and I'll probably do more in a video related to all of the things with the Q&A. But so be on the lookout for that as well. So this pretty much is an add-on code. So remember, if you are in medical coding and possibly a medical coding student, remember add-on codes are the ones with the plus sign. And they can't be used by themselves. They have to be added on to another CPT or HCPCS code. That's just a little game for you for free. Anyway, hopefully you already know that. So this is to help better account for additional resources of visits associated with serving as the continuum focal point for all of the patient's healthcare services needs. So if you provider are the one who is responsible for kind of managing all of the things and having that relationship, because really they have honed in on the relationship for that management with that patient, then this code is for you. And also ongoing medical care related to a patient's single serious condition or complex condition. G2211 captures the inherent complexity of the visit that's derived from the longitudinal nature of the practitioner and patient relationship. So this is when to bill G2211. So think about the relationship. Again, I said it's all about the relationship between you and the patient when deciding to bill G2211. You will bill it if you're the continuing focal point for all needed services like a primary care practitioner, or you're giving ongoing care for a single serious condition or a complex condition like sickle cell disease or HIV. They also give you some examples for when to use there are actually two examples in this MedLearn Matters when to use it. And then you also have information about modifiers. You cannot report, this code may not be reported without reporting an associated office and outpatient E&M visit. And it isn't payable when the associated office or outpatient evaluation and management visit is reported with modifier 25. It says you can add modifier 25 to an E&M CPT code to show that the E&M service is significant and separately identifiable from other services you report on the same date of service. In the Medicare Claims Processing Manual, they give you information for that. However, this doesn't apply to using G2211. And then in the MedLearn Matters that I mentioned before, MM13272, they clearly state they will deny payment for code G2211 on the same date of service as an office or outpatient E&M visit code reported with modifier 25 for the same patient by the same physician or non-physician practitioner. So one of the things that folks were really stressing was, how do you document? How do you document that relationship? What does the documentation look like? And in this guidance, they tell you must document the reason for billing the visit. The visits themselves would need to be medically reasonable and necessary for the practitioner to report G2211. In addition, the documentation would need to illustrate medical necessity of the E&M visit. And it says we haven't required additional documentation. The medical reviewers may use the medical record documentation to confirm the medical necessity of the visit and accuracy of the documentation of the time you spent. These items could serve as supporting documentation for billing code G2211. Information included in the medical record or in the claims history for a patient-practitioner combination, such as the diagnoses, the practitioner's assessment and plan for the visit, and other service codes billed. So yeah, this was part of the discussion on that particular call, but the actual PowerPoint presentation, as well as the audio, I think was also recorded. So that information is out on CMS as well, if you're interested. Mr. Jesse, did you have anything on that?
No.
I know CPT is not your cup of
No.
tea. I know it's not your cup of tea.
I mean, I do remember HCPCS and the add-on codes and modifier 25. I do remember that. I don't know the parts, but I remember.
Okay. So yeah, there's information on that. So check out, and I do also have the links to these MedLearn Matters in the description box as well. So make sure you check out that information. The other thing is I wanted to bring to your attention, because this hit me and I was like, whoa. It's about EMTALA. So EMTALA stands for the Emergency Medical Treatment and Labor Act. And I also have, and I didn't even link my video. I should link my video. I'll link my video too. I also have a video that kind of breaks down what EMTALA is, what you can and cannot do, all of the things related to this. And so on January 22nd, CMS announced a press release to help hospitals meet their obligations under EMTALA, because you will hear often the hospital community up in arms, like, how do we manage this? What do we do? Da 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 da. And CMS must have heard you. And so now they are putting together information. Let me see if I can show this. Yeah, okay. Okay. So here is the information that they're providing for hospitals and for patients. So everybody kind of has an understanding of what is what. So it says you have rights in an emergency room. It's the law. You have these protections: an appropriate medical screening exam to check for an emergency medical condition, and if you have one, treatment until your condition is stable, or an appropriate transfer to another hospital if you need it. The law gives everyone in the U.S. these protections in EMTALA. And this law helps prevent hospital emergency rooms from refusing to treat patients. This law applies to hospitals that receive Medicare funds, which includes most hospitals in the U.S. So if there are violations against EMTALA, there are things to pay. Again, that means that every hospital emergency room must give you an appropriate medical screening. So a qualified professional must check you for an emergency medical condition. When you check in, the hospital can ask you about health insurance as long as it doesn't delay your treatment. So they can't, as soon as you roll in, if you bleeding all over the place, be like, stop, freeze. Do you got insurance? What's your, they can't, that's a no. They have to treat you. They can ask you about it later on, but they can't stop everything just to make sure or validate or turn you away if you don't have insurance. They must treat you until your condition is stable. Again, if you have an emergency medical condition, the hospital must offer to treat this condition so that it does not materially worsen. An emergency medical condition includes when you are experiencing contractions or are in danger of your medical condition materially worsening. And number 3, transfer you if necessary. If the hospital doesn't have the capacity or the capability to stabilize your emergency medical condition, it must offer to transfer you to a hospital that is capable of treating your emergency condition. Before transferring you, the hospital must explain the benefits and risks. Now, they cannot dump you onto another hospital. That's a whole other conversation because there have been cases where hospitals, there may be a hospital in a community that specializes in XYZ, and folks are just automatically dumping patients over to that hospital. That's a no-no. And these hospitals, trust and believe, they fight back. We feel like they sent this patient, they didn't stabilize their condition, they automatically sent. And so that's a no-no. EMTALA exists to help you get the emergency care you need in a hospital emergency room. And again, it talks about what stabilization means and all that. And you can file a complaint. So if you feel like that the hospital has violated EMTALA, there are things that you can do to file a complaint. If you have been denied treatment to stabilize your emergency medical condition in a hospital emergency room, again, you cannot be denied a medical screening, exam, or treatment based on whether or not you have insurance. If you can pay for the treatment, your race, color, natural origin, sex, religion, disability, or age, or if you aren't a U.S. citizen. So here is some information on all of the things. EMTALA. So the guidance for wait a minute. So the guidance is one, they put together this informational resource that we just walked through. They're partnering with hospitals and provider associations to give them additional training materials under their obligations on EMTALA. They're going to convene the hospital and provider associations to discuss best practices and challenges in ensuring compliance with EMTALA, and establish a dedicated team of health and human service experts who will increase the department's capacity to support hospitals in complying with federal requirements under EMTALA. Again, this plan in response to a growing number of inquiries from patients and providers to CMS about how they can ensure that federal obligations were being met. CMS remains committed to helping all individuals, including patients who are experiencing pregnancy loss and other pregnancy-related emergencies, have access to the emergency medical care required under federal law. As you know, EMTALA also includes the Labor Act, and I believe some of this is related to some of the maternal mortality that we have here in the United States. And so I am applauding all of these efforts to get the word out about EMTALA, how important it is. I think oftentimes people don't recognize the responsibilities that these hospitals have as it relates to seeing them and treating them in emergency situations. And all of this information I think is great. It's actually been out here for a long time. But just reinforcing it and making sure these hospitals and emergency rooms understand there can be a fine line, and make sure those fine lines aren't crossed. So I know, Mr. Jesse, this do you have anything on this one?
We all, people in healthcare have heard about this law for quite a long time, but what I don't know is how come there's no information about it. Like, I want to know how many violations or how many complaints they receive per year, and where I want to see the data, because there has to be some kind of way for them to track it. And I think it should be, I'm sure it will, as public information, since it's the government, but they need to publish it, and it needs to be made available, like, to everybody. Like, CMS received this many complaints, and the majority of complaints come from this area, because I think where there's smoke, there's fire.
Well, and I agree. I think with the push for hospital transparency, this could be another one of those data points to. Uh, so you just pinged me. So now that you mention this, this may be one of those things that could potentially be added as a quality measure for these facilities and their funding, because they have several quality measures that they must meet, and if they don't meet them, then their percentages of their reimbursement is deducted. So maybe this is a setup. I don't know. When you mentioned that, I'm like, but I know, working in compliance, we have we've had with a previous organization, we had all types of facilities, and we were in all types of areas, suburban, urban, rural. And in some situations, particularly where there are smaller facilities, actually, we had one here in in Cincinnati. They felt like, speaking of mental health, some psychiatric emergencies they couldn't handle, or they couldn't do something. There was one hospital who pretty much specialized in that. And so everybody wanted to automatically just send them to that hospital. And the compliance officer, you know, we had to have a discussion. We had to have a sit down, like, ma'am, no, because she felt like that, we were dumping. And it was like, no, we have the records. This is what we did. But the type of care that we could provide paled to the type of care that you all specialize in this area. So we stabilized the patient and informed the patient that we would be then transferring them to you. And then there's a process of that whole transfer as well. And we tick and tied and met all of those things. And so that's why you got them. Because she was trying to threaten us, like, well, I feel like that you all violated EMTALA by dumping, da 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 da. No, ma'am, we did not. If anybody know, the receipts. And then and so again after that, because emotions were a little high, like, ma'am, chill. But then we came back, and I was like, so outside of this emergency, let's come back and take a look, and let's get a better understanding of what you are what your capabilities are and what are your capacity related to this. Because one, you have been touted here in this area as the number one hospital that specializes in this area. So we're just one system. There's several systems within Cincinnati. So everybody is sending their patients to you because this is what you've called yourself out to be. So let's have a conversation about that and get a better understanding. Like what does that look like? And so we actually had those conversations, and it made for a better relationship. And she stopped threatening us with EMTALA. Things you have to do in compliance. But
Exactly.
but you're right. I would be interested, like they have all this information, or with the transparency on the fees and the costs for services. Even on doctors, they have like the physician compare. Um, do they have a hospital compare? I'm not certain if they have a hospital compare, but I would be interested to know. Now you're gonna make me dig. So you're gonna add hours to my life. I'll go and see where we can find some information about EMTALA, and even if they don't drill down to the actual facility, at least the area. But you can figure it out. You get the area, you can figure out the facility, where this is happening. But just know your rights as it relates to being treated, being seen in an emergency, in the emergency department. And on the flip side, hospitals understand that you have an obligation, and know what those are. And like I said, I know sometimes it's a real fine line. Like, well, wait a minute, hold up, but you got those. You have to give them a medical screening exam. You have to stabilize them, and if they need to be transferred, they need to be notified, both the hospital that you're planning to transfer them to, as well as the patient, so they understand the risks of being transferred, depending on what's the condition and what's going on. All of that in a crazy, if you think about like ER or whatever, in a crazy situation where everything is going all over the place, but you got to be mindful of all of those things.
And sometimes people have to be admitted to be stabilized. It's not
That's
just,
true.
you know,
That is
so
true.
because the reason why I'm kind of interested in the data is because we know that there's a whole lot that goes into, well, there are so many factors that go into healthcare, that go into reimbursement, that go into taking care of a person in totality. And we know that um, if you have, depending on where your organization is situated, you may have a lot of transient people or people with no insurance.
Mm-hmm.
So they can create a cycle of constant readmission, and that will also affect the hospital's revenue.
Mm-hmm.
So it becomes, you can go down that rabbit hole and stay, because it's a whole lot of factors that go into this. It's not just, oh, well, you go and, we'll give you a pill and then you'll be all right and then go back off. It's way more complicated than that.
It is. You are right. And it goes on and on. The cycle continues. It can continue. Yeah. All right. Well, those are the two topics I think I have for today.
I the, we have, look, you have introduced some topics, and I'm just holding myself until the meeting, after the meeting, because some things are not for everybody.
So again, if you want to get some of this scoop on the things that are not for everybody, join the Patreon. Be part of our Patreon community. Again, we further dissect some of the topics that we share here on the Saturday morning tea. You actually get tangible resources. You have access to actual documents and resources, again, that we provide, that can assist you in either your medical coding career, your health information career, and or your entrepreneurial journey. So we when we find out the information, we share the information, and we feel like each one reach one and teach one, and that's what we're doing over here in our meeting after the meeting with our Patreon community. And we'll actually be adding a couple more little Patreon specific shows, if you will, podcast, video, whatever we're doing here every Saturday. I try to be professional with our video podcast. We'll be adding some additional, probably shorter, quicker, just check-ins, if you will, on information throughout the course of the week. And we're looking at some powerful interviews with some folks to help us. We got some folks who've already gone through some of the journeys that we're speaking of, and so they will come back and maybe give us some additional pointers and some of their experiences, good, bad, and ugly. And we're here for it all. So again, if you want to be part of that journey and that ride, join us on our Patreon. Mr. Jesse, is your class finished? Is it?
No, I started a PCS class so I have a Tuesday, Thursday, and a Monday, Wednesday class now. My Monday, Wednesday class is CM, and that's halfway through, and I just started PCS. So that we have like about another 5 weeks of that.
So was that a totally separate class that you had in addition? I'm sorry, did you make any announcements regarding?
No, I did, because that was for people who had already taken the CM course.
So they're already okay. So it's part of. Okay. Look, I was ready to jump right on you.
You can't jump into CPT without knowing CM. Like, you got to know CM in order
have to know
any procedure code set. So,
Now, have you heard, or did you hear about the what is it? The HCC changes.
Was it version 28?
Yes. Okay.
I've heard about it, and it's risk adjustment period is, when I tell you they are on one, they're on one. Because when our topic last week, I talked to one of my students, former students, is the one who gave me the idea for our topic. But I actually spoke to her this week.
Mm-hmm.
Do you know now the productivity rate for HCCs is 5 charts an hour? Now, when I was in risk adjustment in 2014 to even 2018, when I left, it was like 3 charts an hour. And
wow,
that was kind of rough sometimes. And I'm like, but then 5 charts an hour, and you have to maintain like a 96% accuracy. How?
I swear they pushing this case for AI.
But even I get it, but AI just doesn't have the right context. They have no context.
I'm just saying. We know we on the same page, but I feel like this is a push. This is a push to set the stage for that.
Oh, absolutely, because that's beyond. Like, no.
And I just I don't understand why or how everything is so front loaded. And why is there no consideration for the back? So it's like, just get it out. Just get it out. It could be right. It could be wrong. It could be whatever. Just get it out. Just get it out. Pushing the productivity scale and the production line. Just push, and let them on the back end deal with that. To me, that hurts your bottom line as well, because now you got to also add additional resources, and oftentimes higher paying resources on that back end, because now they have to take the time, the energy, and I don't know that they necessarily have a quote unquote productivity standard for what they have to do, because it can take a lot of time to go through and try to dig and research and find and whatever to figure out what, like for example, your denials management or integrity folks. I know I'm missing one of the words, but the integrity folks that go in and kind of double down to find out why are we getting these denials and what is happening, and then taking that information and then hopefully, if everybody's doing the right thing, providing the necessary education. But what good is even doing all of that if on the front end the push is just to go? Hell, I can tell you, you know what, this is not right. You should do this. Da 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 da. But if you're in your mind and on your back is, but I got to get these out. I got to do this. I got to get this out. Then that's going to be your focus, and that's what's going to be the push. That's going to be the driver to helping you stay employed with XYZ employer versus doing the right thing. And that's just not only in HCC, but just in coding in general. Like, I don't understand why folks don't understand the cycle and connect with the folks in the cycle.
Well, what people have to realize is you cannot have quantity and quality at the same time.
Not in this field. Not in this.
And this is, like when we first started, our Saturday morning tea, even when we were on Clubhouse, I had said that HIM is going the same way of nursing. And this is why nursing is just in chaos. And this is why HIM is devolving into chaos, because there are no HIM advocates because everything is about money. And you have people who have access to these C-suite people, and they're telling them, oh, well, they're being told by the top, well, we need to push productivity, instead of them saying, no, you can't push productivity only but to a certain point if you want to have accurate data. And you just have to rely on these professionals to provide the information as accurately as possible, and it takes time to do that. There's no pushback. So, and what I've also noticed, and that's why I tell all of my students, do not, because I don't do it. I don't do any contracts, not in HIM, because they're ridiculous. And it's because these companies go to they bid for these contracts, they get these agreements, and they make these ridiculous requirements, and they make these ridiculous predictions that all they do is create stress and turmoil for the people that they employ.
Mm-hmm.
Because I think real quick, the last contract I did, it was before the pandemic, and these people, like, I was asking questions, nobody was getting back, because that's another thing. They have people in position who oftentimes aren't even coders, supposed to be your supervisor. They don't answer questions. They don't get back to you in a timely manner. So all that affects your productivity.
Mm-hmm.
So I took this to my liaison at this company. So she was like, well, you're not the only person to hear, to express this complaint. How about if I get a meeting and we all, talk about it? So I'm like, fine. So I knew when the meeting didn't happen that there was something else in the works. So a couple of days after we were supposed to have the meeting and didn't, because I told her, I said, the reason why I'm bringing this to you is because I don't want them to say I'm not meeting productivity. Well, a few days after this meeting didn't occur, why did she call me and tell me that effective immediately I was being let go for lack of productivity? I would have did,
Wow.
and it didn't stop there. Then the company said, well, your lack of productivity was so low that we don't feel as though you were working and we're not going to pay you.
Oh.
And I literally had to file a wage dispute with the state of Arizona to get my final paycheck.
Oh, Lord. Oh, Lord. That is crazy. Beyond crazy.
And if that happened to me, how many other
Did
hundreds of
that happen too? And folks may not necessarily have the wherewithal to understand you can fight. You can fight back. Oh. I just want to real quick, based on your point about not having advocacy for the profession. I don't understand why and how you have all of these people, all of these groups of, I'll just stick with the coders, all these groups of coders in all of these different facilities with all of these crazy productivity standards. Why are they not banding together to fight that, to fight back on that? Like they're just accepting, oh, okay, or oh, well, this hospital says they could do so and so and so, and so it's like we need to meet that same standard. So one hospital will get in the ear of somebody, another hospital or another system, and be like, "Oh, is that what y'all doing? Oh, okay." And then this now becomes the new norm over here at Hospital B. Why? I don't understand. And again, why? And why are they not? Why are they not advocating to find what is a true productivity standard for all? And again, let's be fair, because there can be some folks that's out here just chilling, if you will, and not doing what they need to do. And if that is the case, then they should not. That's a whole other HR issue. Then that person, this may not be the position for them. But to have this, I won't say unrealistic, but unrealistic standard for people and require the level of accuracy or expect the level of accuracy is mind boggling to me. And again, to your point, we got too many, we have at least two national organizations that need to be speaking up about this.
Well,
Where's the
what see what this is all a symptom of is, there is this mindset in America about rugged individualism. And we have long, especially in the workplace, we have long stopped that's it. Sounds like there needs to be a union. Morgan Jones, the reason why there's no union is because people have this, well, I don't need you. That's the rugged individualism I'm talking about. There was a time back in the 70s where 70% of the workforce in the United States was unionized.
mm-hmm.
When Ronald Reagan came around in the 80s, ever since then, they have been chipping away, chipping away. Now it's like some ridiculously low number. If you don't have anybody to advocate for you as a worker, you will always be screwed. And we see it all the time. But you have people now who people are too afraid. Well, I got to do it, and they do it.
That is definitely a conversation for the meeting after the meeting. We're gonna segue right into that. Because maybe that's next. I know hospitals individually don't necessarily appreciate, but I know there are nursing unions. I know, and they fight hard, long and strong.
There aren't
At
that
least
many.
here locally.
There aren't that many nursing unions nationwide. It's not that many,
Oh
and that's
well,
the problem.
they may be okay. Well, I know we have encountered several in our area. Um, and they're fighting, and so maybe that's an additional conversation. Maybe that's where you get the fight. Maybe that's where you get the advocacy that we're thinking these organizations should be pushing for. And maybe it's not even in their wheelhouse. Maybe they're like, well, so if plan A don't work, maybe we need to look at plan B.
Because like nursing, almost every nurse loves to go to California because California has some of the most um, nurse friendly laws because they have a union like
Mm.
this. They have a mandated by law nurse patient ratio. By law, you have to have a certain number of nurses for a certain number of patients, period. And it goes according to acuity. And also in California, if you work 12 hours, um, every place else it's just straight pay. But in California, if you work 12 hours in one day, your first 8 is regular pay, and your last 4 is time and a half every
Wow.
day. Every day.
Wow. Yeah. 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 I see. We talked about an association. I think there's some other things that need to be going along with that association that we may actually want to bring up. Okay. Okay. Well, we are at the top of the hour. Um, Thank you all again for joining the Saturday morning tea or checking out the replay. I hope you felt that some tea was spilled today. Was it spilled today, y'all? Was it spilled
Yeah.
today? Oh. So again, if this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And if as you leave, don't forget to hit the thumbs up or like button, or place a comment. Let us know if this was helpful. If not, or if you have other topics that you want us to tackle and dive into. You can leave them in the comments as well. And don't forget to check out the Coding Nurse channel on YouTube. We will be continuing this conversation in the meeting after the meeting. So, again, check out the description box for the information on our Patreon to be a part of our Patreon community. Again, this has been a great session today. Thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. We will not be here next week, but we'll see you the following week. Have a great weekend and take care.
Bye bye.